So we were talking about teaching at the dental school. I taught there for a fair enough, 5 years maybe.
Okay.
But my lecture schedule got so busy that I kept having to pull back and pull back. But it was actually some of the most fun I had. I love I love teaching graduate students.
Okay.
So grad pros was
Okay.
a blast.
Okay.
I'd probably go crazy teaching undergrads.
Okay.
Because I would probably sit there and go, cut the tooth. Would you please cut the tooth?
Exactly.
Just, make the burr go round.
Yeah.
I remember being a dental student and taking like 4 hours to do something that should take you a few minutes.
Yeah.
And I think that would drive me crazy. But the grad process, I loved doing that. It was so much fun. And a lot of the fun comes from being able to challenge people. And it's harder when you're actually like, you're coming out here from your practice, people are paying good money to be here. They don't want to sit in an audience and have me challenge them the whole day, right?
Yeah,
It's got to be a good experience. But with residents, you can say, okay, why? Why are you doing that? Well, why didn't you do it this way? Why not? And I love that interaction. And I think people learn better too. That's, we talked about mentors and the value of mentors. That's really where a mentor comes into play. A really good mentor challenges you all the time.
For sure.
So you show them a case and you say, okay, this is what I did. And, lots of friends will go, oh, that's so pretty, right? But a mentor will really say, well, why'd you do it that way? And why did you choose that ceramic? Why did you choose that, position for the teeth? Did you ever think about doing it this way?
Right.
So a really good mentor has to challenge you to get better and grow.
Okay.
And eventually, you know when you've got the right mentor is eventually you'll start being better than them, right? Like you'll be able to go when they say, well, why didn't you do it this way? And you've got the answer and they kind of go, okay.
Right. So then how do you even go about getting that mentor? What's your suggestion? For someone wanting to be amazing,
So the way I did it,
okay.
there are two different kinds of mentors.
Right.
There's kind of the big picture mentor. So in 1995, I went and saw Frank Spear lecture at the Sheraton Hotel in downtown Seattle.
Okay.
And I followed his lecture series. And so that's the big picture. That's the big mentor. Like I'm not working with him. I'm not having him come to the office, that kind of thing. But I've got this guy that's given me a direction that I can go. Like, follow me, go this way, right? So those are easier to find, I guess.
True.
There are a handful of them out there that everyone can choose from.
Right.
The harder one's the one in your community. And it doesn't necessarily have to be in your community because there are a lot of mentorship setups where you meet as a group once every quarter or something, all right?
Okay.
But it's easier if they're down the street from you. I think the best way to find it is actually to go to study club meetings in the area. So that would be like you were mentioning you're going to go to a Spear Study Club.
Yes, sir.
Well, in a Spear Study Club, you've got an orthodontist, periodontist, oral surgeon, endodontist, restorative dentist. You've got this group of people. And within that group, you're going to know pretty quickly like what the pecking order of the group happens to be, right? It's going to be pretty obvious because as the videos play and they take pauses to gather, okay, what problems and how are we going to treat it, it will become obvious who the people that have the knowledge are. And then you have to start making decisions. Is that a person that I could see being a mentor for me? Now, it doesn't have to be limited to one study club. It could be the Spear Study Club. It could be your local dental society. It could be there are lots of different ways of coming up with opportunities to be in the face of other dentists, right? So don't limit yourself of, oh yeah, I'm a member of a study club. It may require a bunch. Okay. But I think the only way to really figure out if someone knows what they're doing is either to work with them or to be in that setting with them.
Environment.
And and then you hear their thought processes. And if that resonates with you, and I always tell my kids this, sometimes you just have to take a deep breath and say what you want to say, which is, I'm looking for a mentor.
Right.
I would love to be able to run cases by people,
right.
and I love what you're doing.
Right.
Would you consider doing that for me? And then I think you said you met with your endodontist every so often, right?
Yep, every Friday.
You could be, every Friday we're going to talk about, or every other Friday we're going to talk about this with a restorative dentist. Or it could simply be, whenever I get cases that I'm challenged by, can I send you those?
Yep.
And we discuss those. But you got to put in your effort too, right? If someone came to me, actually someone not too long ago came to me and mentored me, said, would you mind mentoring me?
Mm-hmm.
The problem was they really wanted me to teach them.
Mm-hmm.
They didn't want me to mentor them. Mentoring means you do the work.
Right.
And I oversee what you're doing and ask questions.
Right.
Teaching is I do the work and I tell you. And while I enjoy teaching, that's not where you're going to get the most value.
Yeah.
You're going to get the most value if you do the hard work and I quiz you on why you did it that way and give you other ways to look at the problem. So a mentor needs to not give you all the answers. A mentor needs to ask you all the right questions.
Ah, that's good. That's good. So then what we were doing today, you were teaching us, and then the best thing that we get to do is go back home and actually do something about it. I heard you say that a lot today. Doing something about it, which is something that younger dentists might not have a lot of experience with as far as hard cases. So what's your suggestion on that?
I keep falling back to Frank Spear. The thing that resonates with me in one of the reasons that he set up this center is he wanted a center that allowed people to rise to the level of confidence and competence that they chose.
Okay.
So whatever that happens to be.
Our choice.
Yeah. So if you want to do the hardest of the hard, we've got enough material here and enough good teachers that we can teach you to do that, where you can go home and feel comfortable with it, right? A young dentist has to feel comfortable that they are competent enough to do the case.
Okay.
And you have to build a foundation of education first.
Yep.
And it's hard to say because the patient walks in and you can see, I ought to be able, they need all their teeth done or whatever it is, whatever the challenge is. And you want to do it, but you don't have all the pieces yet. And so it's a matter of continuing that education. It would be so nice if it didn't require any effort.
Right.
Like it just happened, right? But it just requires continued effort. And the people that end up doing those cases quickly, like when they're out just a few years, they have busted their butt trying to learn how to do it. And then the mentor comes into play, which is you go through and say, these are the photos I've made. This is where I think the teeth belong. This is the plan that I put together. Now the person that has done it can guide you through. And once you've done a few cases, they all tend to they repeat themselves.
Right.
It's not like each case is this incredibly unique experience. It's just a matter of getting the first few knocked out. So I guess don't rush, but don't lag behind in your knowledge base.
Okay.
So it may be that you don't do that case yet. It may be that you keep that person on hold for a while knowing you could get to it, or it may be that you refer that patient out. Interestingly, another way people learn is I've had a handful of people refer me cases and they just stand over my shoulder and watch.
Yeah.
Or if they're out of town, I photograph the whole thing for them and say, this is what I did, here's the next step, here's the next step. And so the referral instead of doing the case is sort of like, that's what it cost me to learn this procedure. right? And you may not have done the case, in which case it's kind of a free way of learning it, right? If I get to do it, you weren't going to get to do it.
Yeah.
You're learning for free.
Yeah.
So if you can find someone to do that, that's a cool experience. Now, you got to find the right person, right?
Again, relationships.
Yeah, because you obviously would like to learn it correctly.
Yeah.
Right?
That's true.
You'd like to not have to relearn the experience or have the experience over again.
Very true.
Yeah.
Okay, so today you talked a lot in a lecture about some common threads that I picked up. So physiology, data, just awareness, all of those things. How do we put all of that into practice and join it together? Starts with the awareness, and then how do we find them?
Yeah, we were talking today, the course is airway prosthodontics.
Right.
And so I mentioned yesterday that I hate even calling it that. Right. I just think of it as dentistry. This is just how I do dentistry now. Yep. The awareness part is realizing that some of the malocclusions we see and some of the damage we see is actually related to airway problems. Either they had airway problems as a kid and therefore they grew that way, or because they have airway problems, that's why they're causing the damage to occur. And so awareness is just being able to look at a patient. In fact, we did Paul, and I said, this guy walks into your office, you go, oh, hey. And as he smiles, you see his arches narrow. Right. You're like, well, that's not right. Mm-hmm. And then as you do a dental exam, you see wear, and you see constriction, and you see missing teeth, and it all starts adding up to a story. And the story started when he was really young. Right. And how the orthodontist had to adapt to the lack of skeletal development. And that how the orthodontist, through that adaptation, created an environment that in the long run created wear in his teeth. And that we shouldn't just be putting veneers over worn teeth. We really ought to be aware enough that we could maybe make him better by reversing time, essentially, for him. Mm-hmm. And so the awareness part is you have, it unfortunately keeps coming back to you got to put in the effort to learn about all the different pieces so that when you look at this patient named Paul, you go, well, this is really obvious. Mm-hmm. It's this and it's this and it's this. The other part on gathering data is if you tell a patient your arch is constricted, you've got this, you've got wear on the teeth, how do you convince them to do something about it? Mm-hmm. Now, one way is you say your teeth would look better if we put them here. One way to do it is your teeth will function better. Your bite will be better. All right. But I've been doing this 30 years, and you can sometimes sell aesthetics, and you rarely can still sell a better bite. You know, like, oh, you're going to bite better. Yeah. I don't care. I bite fine. Right?
Absolutely.
But you can sell health.
I love that.
Right? If I say, if we do this, I bet these medical issues or some of the other things that are going on are going to be better. You may be healthier in this position. Now you get their attention. And when you get their attention, then you can formulate a plan. Now, what gets their attention better? Me saying, I think if we do this, it's going to make you better, or what if I could prove it to you? So proving it to you. So we do some screening where we say, this is what you're like now. This is what we think you would be like through simulation down the road. Would you be interested in doing that? Yep. Now we've got their attention. And now, the patients always say, I'm not doing ortho. Now we get people to go, when can we start the ortho? Right. Yeah. It's crazy, actually. We have a procedure we were talking about called Dome, where they make cuts along with the ortho. I had a lady begging me to call the surgeon because he only had one time slot. Please get me in for that one. I mean, when do you hear people want to do ortho and surgery? I've never heard that. She was like a month ago, please call him and get that spot. Right. I don't want to wait a couple more months. I want it now. Nice. So crazy how dentistry changes. And by the way, at the end of that, you always get to do dentistry. Almost always. At the end, you get the teeth in the right place, and you have to do something to repair it. And you were asking me, how do young dentists learn how to do bigger cases?
Yes, sir.
The best way to do that is get an orthodontist to put all the teeth where they belong, and then the dentistry becomes so much easier.
Yep.
Now it's something that's right in your wheelhouse, but it's a bunch of dentistry. And you can do the dentistry because the bite and the teeth are in the right location. You could do it over time. So I'm in San Antonio, Texas. I'm not in New York City. So
Right.
people can't just write a check for tens of thousands of dollars to me. But those cases, once the orthodontist sets them up, I can do a little now and a little next year. And if you're not comfortable as a young dentist, which I wasn't, saying big dollar amounts, you know, please write me a check for whatever.
Yeah.
I mean, I couldn't get the word out.
Yeah.
I remember I was asking one time a person to write a check for a dollar amount I didn't have in the bank. And I thought,
normal.
I don't know how to say this.
Yeah.
And I just fretted over it. Like, how am I going to say that word when I couldn't possibly write that check? Well, now you can say, well, how about we do these here? You know, we'll do this year, and we'll do this next year, and we'll do that. I can say those numbers easier. And my patients can afford it easier too. So being aware is, I think there's a problem. Being directed is, I'm going to gather data, and the data helps me sell treatment plans.
Nice. So just to switch gears here a little bit, your communication is so strong with the treatment, the planning, and things like that. How would someone go about putting those skills to use?
The
really
communication part, is that what you with the patient?
Communicating with the patient and with your staff too, because sometimes, you know, in dentistry we are not trained to be strong communicators or leaders within the practice. We want to just do the dentistry.
I apparently the only thing I can answer is I would listen to Frank Spear.
Yeah.
Frank Spear is the best communicator I've ever heard.
Really.
He has a course on the art of treatment planning where he spends a significant amount of time going through how he goes through the discussion with the patient. And at Spear we have gobs of videos where Frank is having that same discussion, all different angles and we have a whole section set up for our staff as well. So your staff can learn with you how to communicate within the staff. We also have a Spear Practice Solutions program where we've got mentors that help you develop that skill along the way, because it's an important aspect. If we're going to look at, so I'm going to take a little detour.
Let's do it.
When I hired a consultant to come into my practice, all they did was look at numbers and say, this is what you need to do, whatever. Right? Spear Practice Solutions takes a different direction.
Right.
And it highlights what you just said. Yes, they look at the numbers. They do that.
Yeah,
but you've got to be better at selling treatment plans. Your staff has to be better at assisting you in selling treatment plans. And then you have to be able to do all the stuff you were thinking about, right? So you got to think it up, get them to do it, and you've got to actually do it.
Yeah.
Right? Spear Practice Solutions is not like a regular old consulting company where they come in and go, okay, here are the numbers, and you're doing, oh, you need more new patients, whatever it happens to be.
Right.
Spear Practice Solutions says, what's your goal? You want to do this? All right, here's how you have to do it. You need to, what we're seeing here is you need to be better at closing sales on cases. But more importantly, you need to be able to think more globally in your treatment planning. You're too focused on what dental school taught you, which is structural issues and biologic issues. You need to think about aesthetics and function and come up with bigger, better treatment plans to sell. All right, now that we've taught you and your staff how to think bigger, how do we sell bigger? How do we get people to do that? And then once we get them to do it, how do you then capitalize on that and actually create the dentistry to where now you have a library of work that you can reference both intellectually, but also you can show patients, I did this on this patient. I mean, think of how powerful that is. You're a very young dentist, but if you all of a sudden had 10 incredible cases of all different varieties that you could constantly sit with a patient and go, your mouth looks like her mouth. And here's what we did for her. Would you be interested in that? That's way easier to sell than, let's look at the piece of paper. Here, let me talk you through, right? That doesn't sell as well. So Frank Spear is as good as I've ever seen. I would spend time with him.
Yeah.
So he does the lecture on art of treatment planning that I think is amazing. And then he and Ricardo Matrani are going to be coming up with some new courses that are coming up 2022, I believe.
Okay.
And at the beginning. And it will be completely focused on what you were just talking about. How do we get better communication with the patients so that they're going to start doing more dentistry?
Nice. So the one thing that we haven't talked about just yet is sleep and airway.
You know that was a hot, like a,
Yes.
I'm going to push it a little bit.
Yes.
Okay, we'll talk about it.
Can you tell us a little bit about it? Because in dental school, as you know, we were talking previously, we learn about sleep, OSA, appliances, and things like that.
It's actually good that you learned that.
Yep.
Because a lot of dental schools don't even teach that.
Yep.
So it was great that Florida provided you that information.
Yep.
So they created an awareness.
Yep.
All right. The way, though, that we're taught in dentistry, and I did this for years, so I'm speaking from the point of view of someone that's gone through this.
Yeah, past experience.
I made appliances for years, and my only focus was making mandibular advancement appliances for people that had apnea. At the beginning of the whole thing, it was like the Wild Wild West. You can make whatever you want. You didn't need any guidance. It's like, oh, you snore, let's go, right? Then it became more regulated, where I had to have a sleep study from a physician and a letter of medical necessity in order to make it.
Okay.
And so I formed relationships with sleep physicians and started making a bunch of these.
Okay.
All right? So I was doing sleep dentistry.
Okay.
Problem. So there are three. First problem is that it was really just focused on the fat old man that had apnea. And I kept finding kids and TMD patients, young female kinds of patients that had airway problems.
Right.
But they didn't fit. I mean, like, what am I going to do? Send them in, they're not going to write me a letter of medical necessity on a 4-year-old to make a mandibular advancement appliance, right?
Right.
And so my model didn't fit what the patients I was seeing. And so I started getting frustrated because I would send those patients in, and the sleep studies weren't providing me any guidance anymore, right? So that's one of the first problems, is it really focuses on apnea. And I think a lot of the patients that you and I see in dentistry are we'll call them the pre-apnea patient. They are symptomatic from a malocclusion, bruxism, reflux type of standpoint.
Right.
But they haven't gotten sick enough to really catch the attention of medicine at this point in time.
Is that where your interest in airway came?
Yeah. Came from bruxism, actually. So my interest was in bruxism. I wanted to figure out why people ground their teeth. And so I started looking into that.
Okay.
And actually, that's part of the evolution, because sleep talks about apnea. And I thought, because that's what I was doing, that there was a relationship between apneic events and bruxism. And there's a very weak relationship between true big-time apnea and bruxism.
Right.
The relationship is on lower level events, inspiratory flow limited breathing. So the airway begins to shut down and the body reacts to it. So people that grind are very reactive to things. So if I sent that patient in and got a sleep study done, they'd say, no, they don't really have apnea, but they ground a lot. I go, so there weren't any relationship. And it was disappointing until I finally realized they just weren't testing for what I really needed them to test for. They needed to be testing for these little events, and that's rarely done in sleep laboratories.
Right.
Okay, so we know there's a relationship between these airway types of events and bruxing. And so yes, it's that fueled this idea that we're missing something by just focusing on sleep. Okay. Right. The second problem that I had was that if I got a patient that came into my practice that had the sleep study and the letter of medical necessity, I always did the same thing. I made a mandibular advancement appliance.
Right.
That was it. And for years I didn't think about it. All I thought about is, this sucks because I changed their bite. A lot of people didn't like it. They wanted their money back, or it didn't work, right? So I was frustrated by it. but I didn't think through the whole process.
Right.
And then it finally, when I was really more focused on airway, I realized, there are a whole bunch of people that I've made night guards for that said, I can't sleep without that thing. And I've had a whole bunch of people I've made night guards for that said, my wife told me I stopped snoring when I started wearing this thing. And all of a sudden I'm going, it's not that I fixed the second molar interference and made the occlusion perfect. It was that little bit of vertical dimension was enough to make them breathe better, sleep better.
Yeah.
And that led us on the trail of trying to find the appropriate appliance for the patient that we started today, the Seattle protocol. And it's a provisional way to find the right appliance. So instead, in my practice, instead of always making mandibular advancement appliances, I make appliances, but I make the right appliance.
Right.
So it may be a night guard. It may be an anterior repositioning splint. It's the right appliance for that particular patient rather than always being that one particular device time and time again, right? And the other flaw that I saw in sleep dentistry is, so they showed you to make a mandibular advancement appliance, right? What do you do after that? What's the next step? Well, there isn't one. Right? The next step is you continue to manage them and eventually you have to replace it, right? How does that make sense? Why wouldn't I get them under control and then try to make them better somehow? Because we know that almost every case you're going to see began as an anatomic problem. So why not make the anatomy better? So I like CPAP and mandibular advancement appliances don't make sense because it's like, okay, you've got a disease, here's a Band-Aid.
Right.
You're done. And we never try to maybe clean out the wound and get them healthier and let it heal.
Right. It's back to health again.
So that's what we want to do.
Yeah.
So the difference between sleep and airway to me is a chasm, a huge chasm between those two. And when people use the term, that's what we were joking about earlier. When they use those terms interchangeably, it bugs me.
Yeah.
Because they're not the same. They're not even close to being the same.
Yeah.
So
for
you're not supposed to ask me questions like that.
Oh no.
That like poke at me.
Oh no.
That's one of my sore spots.
No, that's a good question to see if there's any alignment. But no, that was good. That was good. The question that I do want to ask about is any like interdisciplinary like encroachment. Have you ever had any doctors who are like, because I'm a general dentist, so here I am, I come out this beer, I'm excited, I've taken this course, and, I go back home and I want to get started.
I had more, like, upset physicians when I was just making mandibular advancement appliances.
Really?
And the reason is that first of all, a lot of physicians still don't believe mandibular advancement appliances are a solution or a treatment for sleep apnea, right? They'll say, oh yeah, if it's really mild, we'll send it over. But past that, no, that's not a treatment. Okay. And so then when I would push, like the patient failed CPAP, I'd call up and go, hey, they're not using their CPAP. I'd like to make a mandibular advancement appliance. Could you write me a letter of medical necessity? Then we would have to deal with the conflict there. The only battle with an ENT is like, do I do ortho before I do the surgery, which would be the appropriate approach. I had an I had an ENT in my office for 5 years. Okay. So he was ENT, sleep, and facial plastics. Okay. And he worked at a children's hospital in a fellowship. So from tonsils and adenoids on little kids all the way to complex ENT, he could do all of it. Mm-hmm. And it was neat because we formed this relationship of, you know, I could think a little bit like he thought about when I saw a patient. So I could kind of hear him thinking when I looked at a patient that came in. So ENT and dentistry are really very compatible. Mm-hmm. We see the world the same way. The part we don't understand, and there's an ENT that's in the course today. Right. What he told me is, I never knew you could do those things. Mm-hmm. So I spent all my time learning what an ENT could do because I wanted to know how to incorporate that in my treatment plan. Physicians rarely come to dental meetings, spend any time with dentists, or learn what we can do. They have very little knowledge of dentistry. You know, kind of the joke always is a dentist's got a way better chance taking a good medical history than they have looking in the mouth and figuring out what anything is, right?
Yep.
Okay. So I spend all my time learning what an ENT can do, but they don't learn what we can do as dentists. So he was amazed at some of the things that we could do. I mean, we can completely take his area and transform it into something so much better than what it is.
Yeah.
You see, ENTs, for the most part, not facial plastic guys move bone around, but usually what ENTs do is they take a given skeleton and they make normal things fit within a small structure. So small skeleton, soft palate, how about we cut it away? Now it fits. Tongue looks large. How about we cut it away? It fits. Septum won't fit. How about we cut it away? It fits. Instead of thinking, tongue won't fit, how about we make the arch bigger?
Expand it.
Palate's really long. How about we move it forward? Nose doesn't work. How about we expand the maxilla because that's what it's looking for is space. And so we need that collaboration.
Right.
But we also need to, in your Spear Study Club environment,
I was going to bring that up too.
bring in physicians.
Yeah.
Now it really is a great environment. Some of the newer study club modules are going to be airway modules. So we have 2 of them out now. And so we've built on the FGTP concept, facially generated treatment planning, and we've now added airway in. So it starts, that would be the time. Those are the meetings you would say, hey, call the ENT and have them come over because I think this will be interesting for them.
Nice. Well, that's all the questions that I have for you.
Yeah. Good. Thanks so much for
thank you.
talking to me. I appreciate it.
No, this was good. It was really good for me. Thanks for taking time.